Hello, viewers, and welcome to Healthy Wrinkles channel, which is devoted for better health care of all senior citizens. Today, we have with us Dr. N. Prem, who specializes in geriatric medicine. And before we begin the conversation, I will just briefly introduce him and the kind of work he's doing. As I mentioned, Dr. Prem is MD geriatric medicine. He has done his MD geriatric medicine from Amrita Institute Medical Sciences at Kochi. Currently, he is head of geriatric medicine unit at Jaslok Hospital, which he established himself a few years back. Prior to that, Dr. Prem has also worked with the Department of Geriatric Medicine, All India Institute of Medical Sciences, New Delhi, another prestigious institute, where he has worked and served also as an assistant professor. Dr. Prem has conducted multiple support groups, talks, webinars for senior citizens, and also for their caregivers. He has written multiple geriatric updates, and is also founder member of research wing for Indian Academy of Geriatrics. Dr. Prem's areas of interest include geriatric syndrome, dementia, urinary incontinence, orthogeriatrics, community geriatrics, and preoperative care for the elderly. He believes in establishing a continuum of care from hospital to home and to the community, which is a very important aspect. We are going to have a conversation with Dr. Prem today, and I once again welcome Dr. Prem for this conversation.
Thank you, Mr. Shriyari, for that introduction. It's great to be here.
Yeah. So my first question, doctor, is to understand that this is relatively a new branch of medicine emerging very rapidly in the last few years. So what is this branch is all about, and how it is different from rest of the specialties? If you can highlight that, that might be of interest to the viewers.
Yeah, so geriatrics actually is, as everybody would have heard, pediatrics. So pediatrics is very familiar, that it takes care of children, infants, and of course to a certain adulthood age. So geriatrics was actually coined by Ignatius Nasher in the year 1909, when he actually said that if pediatrics can be separate, then geriatrics also needs to be separate. So it is basically from geros and itrikos. Geros means old age, and itrikos means healer. So that is how geriatrics came into being. Now, that's about the word geriatrics. Now, as a specialty, yes, it is very nascent. You can say in 1996 was the first real establishment of geriatrics, which happened in Madras Medical College in Chennai. But now, it basically concentrates on something known as holistic care for the older person, wherein it epitomizes the definition of health. To be very frank, geriatrics is about taking care of the physical, mental, and social well-being of older people. So it's not only about the medical part, it's also about making sure that socially they are viable, mentally they are viable, and ultimately the focus is on something known as quality of life, because functional independence matters a lot to older people. And the more independent they are, the more they are happier, and the more less care they need, because health is something which is the common link. If you're unhealthy, then you tend to be more dependent. If you are healthier, then you tend to be independent. Another thing which is important as a framework is that geriatrics epitomizes a holistic interdisciplinary care which can be given not necessarily by the geriatrician but by a team. So usually the team leader is the geriatric medicine person, and it is taken care, or an elder care specialist, as you can put it in simpler words, and with the help of a lot of team members. It could be a physiotherapist, it could be a dietitian, it could be a psychologist, a social worker. Very important, because the social paradigm is important. Treatment what we are offering, whether they can afford, if they cannot afford, can we actually help them through it, because we need to know that aspect as well. Then other team members come and go. For example, three things are very important in geriatrics: one is vision, one is hearing, and one is dental. These three things, once they get weaker, the quality of life gets affected. So a dentist, an ophthalmologist, an ENT specialist might or might not be needed. Now the strength of a geriatrician is a referral is done only if needed, or else it is comprehensive holistic care as far as the older person is concerned, and the geriatrician can take care of there. Another thing which you had already mentioned, which I would like to stress, is it's not only care in the hospital. It's about hospital, whether it's OPD or whether it's inpatient, then ultimately extrapolating that to home. And our best efforts would be to make sure that the older person comes back to the community back, or at least to that level of independence where they were before. So it's not only about medicines, but it's about a holistic care in which is done comprehensively. And that's where something known as a comprehensive geriatric assessment, which is a framework which geriatricians follow and which I follow, so comes into the picture, where when an older adult comes to us, it's about saying that we don't miss anything. I mean, because we don't miss anything, and we create a problem list wherein every problem is important. For example, if an older person has a pneumonia, then yes, I have to address it because it's an acute problem. But that does not mean if the older person has depression, then I don't want to address this. If the older person has a history of falls, I don't want to address this. So everything has to be addressed. And as we go ahead, the addressing might need other team members, plus minus. So that's how geriatrics works. Another thing is, two people are very important to that team. One is the patient themselves, which is very crucial, and one is the caregiver, because the caregiver could be an 80-year-old taking care of a 75-year-old or vice versa. So that is something. In geriatrics, we never forget the patient behind the patient, because if we neglect the caregiver, then maybe the care of the older person per se will be affected. So this is about, maybe in a nutshell, what geriatrics is and how different it is. Another thing I would like to stress is time. You need to give time to older people, and geriatricians have time. I mean, you have to give time to older people because they need to express all their problems. And once you build rapport with an older person, then sky is the limit. They are able to share problems which they might actually be hiding at home also, because they feel that maybe it's not, for example, urinary incontinence. It's a social sort of thing that, oh my god, I've lost control on my urine. I'm an independent person. Suddenly I'm not able to win control my own urine. So those things, actually, if you don't ask, they sometimes don't come out of it. So such small things which actually are pretty huge and should never be neglected. Typically it is just put into age. So I would say we have to always delete the ageist attitude and try to get things into perspective.
Yeah, I think wonderful, doctor explanation, and I understand. I think the key aspect is a holistic, approach towards managing the individual, and individual caregiver and other team is very important in managing that. And geriatrician will take lead because he or she will try and understand the individual holistically. I think very important point. How do you, Doctor, but typically collaborate with, say, other specialties? Because currently the individual could be taking, consultation treatment with other specialties for one or two problems. So how do we typically collaborate with other specialties?
So I would say always the focus is on holistic care. So for example, if somebody is going to the cardiologist and they need the cardiologist, then we coordinate with the cardiologist, making sure that these are the things we want to do, and these are the things the cardiologist or the nephrologist wants to. Now, make no mistake, everybody, they also want to take complete care of the person, but they are more organ specific purely because one is they are trained for that, and secondly is they have to take care of other patients as well, because it's organ specific care. For example, if they have a cardiac care and there are four more patients after the older person waiting for a heart checkup, which is equally serious, so they need to prioritize and they actually have to go ahead. That is why we come in, wherein we try to make sure that all the medications, all the sort of advice which has been given, try to centralize, make it more centralized, wherein they can come to us and we can actually try to help them out if they need to go to a specialist. Then for, I feel, interventions like fall, in which we need to have a fall assessment, that can be done by the geriatrician and the physiotherapist together, because that is how a fall clinic can be done. Then things like memory clinics, wherein a coordinated effort between a neurologist, geriatrician, and if needed a neuropsychologist. So this is how we try to collaborate with other specialties, surgical specialties especially. I feel, for example, pre-op assessment and post-op care, which can be done especially for geriatric patients, because a lot of things can happen. And orthogeriatrics, which is of course a very much an upcoming field as far as orthopedics and geriatrics is sort of concerned. For example, an acute hip fracture happens, then the protocol in which, when we were working in AIMS, we actually had a protocol wherein we had beds for orthogeriatrics. So we were actually making sure that pre-op everything is adjusted and post-op we take care. So that's how those coordinated efforts can actually be taken care. See, the motto is to give the best care for the older person. So when you need another specialty, yes, the help should be taken, purely because ultimately whatever we do is going to affect their quality of life, which is something I think which is paramount.
Right, I understand. What are the three or four top healthcare issues that probably you have noticed or you have experienced, and what all solutions can be provided with all the stakeholders together? So if you can throw light on that.
Yeah, so specifically, I think in elder care, yes, there are always the known, I wouldn't call evils, the known diseases which affect them. So in that, I feel, I mean, if you put it purely medical, I think the coronary artery disease, diabetes, hypertension, these three are sort of core. But and hypothyroidism also. So they come in more of comorbidities. But what are specific geriatric syndromes are some things which actually affect the older adult in such a way that it's not only one system, multiple systems are affected. Now these are, I mean, the three Ds are there. One is dementia, because the dementia, I mean, a person is very scared. I mean, even normal older adults are scared that they might sort of not be able to remember. I mean, even at younger age group, even we will be scared that what if one day we are not able to remember, because it's a scary thought. That's why we encourage older people to actually get their memory tested, because see, it's very easy. You do the memory testing. If we diagnose something earlier, we help you earlier. If we know, then at least for that particular time you feel okay, our memory is fine, and we can actually help you to do some memory aids wherein you sharpen your memory. So there are some brain exercises. See, the brain becomes very bored, so you have to give it challenges as you get older, also learn a new skill, so things like that. So that's where collaboration with psychologists comes in, collaboration with occupational therapists comes in. Specifically try to give them that non pharmacological interventions, not only medicines, so both go hand in hand. So that is about dementia. Then depression, I think depression is very commonly missed, purely because it is just branded on age. As I mentioned, no, most older people, these are myths of aging. Most older people will be depressed, and most older people will have memory problems. It doesn't work that way. So depression is something you need to detect. Why? Because it's treatable. I mean, you can treat depression, and it's not always medications. Counseling is fine. You can actually counsel older people and they can get out of it, and they do. uh, Depression has really hit them bad during the pandemic as well, because suddenly healthier adults who could actually go freely outside could were confined to their homes purely because for the health risk which was involved. But then that's what I feel. Older adults adapt. They learn Zoom. We as an organization in Graceful Living, which we can talk about in another video, of course, is that we made sure that they were technologically trained, and it had its hurdles, but then we realized 9 months down the line they are pretty much good at it. Now they have an option wherein they might say, no, I'm going to join your meeting not in person in future. They'll be like, I'll do it online. I mean, because they can do it. So we have learned from the older adults that they have told when challenges are thrown to them, they adapt. So that's how the depression and anxiety was taken care during this particular pandemic. Then delirium is something which is just acute confusional state, wherein people can actually forget for that particular time. It could be due to infection, it could be due to medications, it could be due to electrolyte disorders. So that has to be treated, and then they will be fine. Again, every syndrome that I'm talking to you about is actually a separate topic, so which we obviously can take in future sessions as well. Then urinary incontinence, something which is easily missed. Oh, I lose control, maybe it's because of you, it's because of age. Another thing is, oh my god, as I mentioned, I lose control and I'm going to tell my son, my daughter, that I'm not able to actually sort of I mean, I'm wetting my pants, to be put it in very common layman. But if we detect it, there are ways of treating it. I mean, the acute infection, urinary infection could be a cause. So you treat the infection, the incontinence will improve. And there are other causes like through cough induced, where you actually lose, when you cough, then you will lose control on your urine. So you have to tackle it. We might plus minus need a urologist, maybe at a later stage. So those are, as I said, when specialties are needed, we obviously need to consult them. Then in bedridden patients, we are worried about pressure sores, because skin integrity goes as we grow older, and we hate, I mean, I hate it because I know that the person is on the bed. The further away the older adult is from the bed, I am more happier. The more closer they are to the bed, I'm a bit dicey. So that is one thing, because it needs utmost care, and it has a lot of stress on the caregiver monetarily also, and the older adult might not in a state where they might not improve. Then falls. I think falls kills an older person, purely because a near fall. Sometimes they don't fall, and after that, suddenly a normal active person doesn't want to go out. They're like, because something known as fear of fall. So that again can be tackled in a coordinated effort where we try to get out of them what the cause was, because there are a lot of causes of falls. Try to see. It could be as good as a slippery floor at home, which nobody is sort of thing. Bathroom, the commode height not actually being adequate enough. So when they go actually sit down and get up, they are not able to have that balance. Then things like vertigo, which they feel is we are having a dizziness, but I actually stand up and it's okay. But when it happens in the bathroom, it can be fatal. When it happens outside, it can be fatal. So falls also, I think, are something which are very important. Then there are, of course, the common things which should never be neglected. Constipation, it is highly irritating, and it can actually make that older person only think about it. There have been cases where in my patients where they have diabetes, they have hypertension, everything is under control, but the fact that they are not able to pass properly makes them depressed. And yes, I mean, if you and me just imagine not going for a single day, I mean, we are just absolutely, I mean, the mood is bad, you don't want to eat anything. So that is another thing which is something which has to be sort of tackled very much. So this overall are the problems. And always remember, the more diseases they have, that's why I mentioned the multimorbidity state first, the more it will be difficult for us to tackle. The lesser the diseases, the more easier it will be tackled. Again, age is a number. A 90-year-old with no disease is fit, whereas a 65-year-old with multiple diseases will be more vulnerable. So that's how we in geriatrics try to think and treat an older person, because a 110-year-old will be living that way because they have done something right. So flexibility is also a key as we treat older people more. You cannot always say that no, your sugars is 150. According to the guidelines, it has to be 140. So we'll make sure that we'll we are more worried about hypoglycemia because the sugar going low, because that can lead to a fall. And so things like that are very important. Another thing I think is drugs. The number of drugs in an older person, sometimes it's an essential necessary evil, purely because if they have multiple diseases, they might actually have to take multiple drugs, which is known as polypharmacy. So something is known as essential polypharmacy and something is non-essential. So we need to cut down the drugs which are not essential. For example, we have seen prescriptions where there are 5 types of vitamins just being written by different specialists. It's not that they don't want to check the prescription, they do, but then sometimes older adults take only the specific prescription. The cardiologist prescription is only taken to the cardiologist. And then we see 5 types of vitamins and we cut down all, because it's like all it's adding is just nothing, because a certain dose is enough. So that's why the drug review also is very important. That's why you can do it, and help of a pharmacist is also very important, because I mean, to be very frank, in a very good setup of geriatrics which happens in abroad, geriatrics we are actually picking up in India for definitely, and it's well on the high, and we are doing very well. But abroad there is a pharmacist who makes sure that the list of drugs is seen, because two drugs sound similar. What are the challenges? Looking at the prescription is a challenge, looking at the strip is a challenge. Are they taking the drugs themselves? So you as a geriatrician have to see all those things, because ultimately when you tailor made the prescription, you need to know what side effects cause, because there is sometimes what happens, one side effect is treated, so another side effect gets treated. So ultimately it leads to prescription cascade, wherein you have multiple drugs, whereas only one drug had to be stopped or changed. So that's why I feel whenever in geriatrics, the true wholesome, you can say, interdisciplinary approach, which is always followed, helps an older adult because it's always comprehensive. And ultimately, long-term care is put into mind. I don't mean long-term care is long-term care as such. I mean futuristically. For example, if I'm seeing somebody now and I do that comprehensive assessment, I am not only planning for the next visit. I want to make sure that preventive care wise, we can look ahead. That's where vaccinations come in. That's where diet, lifestyle, exercise comes in. Elders can be very disciplined. They are already are sometimes. And I think one of the most important things is communication. When I'm dealing with an older person who's 75, I mean, to be very frank, in my practice, all my patients are older than me. I mean, that's a fact. So I learn from them. So the way you talk to them, Some older people like you to be very friendly. Some might not. Some might be that they are very guarded and they just want to tell about their disease. So you need to know how to talk to different, because the word is heterogeneous. Every older adult is different, and that is the beauty of geriatrics. That's why you need to tackle everybody differently. And with challenges comes, I feel, ultimately, I would say, at the end of the day, it's the several blessings of the older adults that we get, and the experiences they have in life, and we learn from that. So that's what. So I will say the older adults are the most biggest resource which we need to sort of tap in every way, in every sector. And as a professional who's taking care of them, healthcare professional, I think one of the keys is giving them time, because once you give them time, everything flows.
Thank you, Dr. Prem. I think it was a really very good, very valuable conversation, and you brought up several new points. So rather than looking at it only from the medicinal perspective, I think you broadened the perspective how you're looking at care to the elderly, and several new dimensions also I think you introduced. And I understand that within probably, our today's one interaction, we are not going to cover all of them, but we look forward for more interactions with you, and we
Absolutely.
pick up one topic every time, so that the viewers will really get benefit out of the kind of work that you're doing and the kind of efforts that you're putting. So
Absolutely.
thank you once again, Dr. Prem, for your time.
Thanks a lot. Thank you. Thanks for having me.